course this fall, we're going to look at what's known as pulmonary function tests, PFTs, as they're often referred to, or pulmonary function studies. And these are going to be important in diagnosing a patient with pulmonary problems. And they're going to be very important to you as an anesthesia provider because you're often going to see these types of values that the patient is accompanied on their chart. So you're going to be able to look at their pulmonary function studies to see what types of problems may occur, ventilatory-wise for you as a nurse anesthetist, and you're able to plan your anesthetic accordingly based on the patient's pulmonary function or lack of pulmonary function because of the fact that they have various disease entities. So these tests are very valuable for you as a clinician in determining the best anesthesia care delivery for the pulmonary patient. And you can see the objectives of the course. These are overall objectives for the particular course. So pulmonary function tests really cover three aspects. So three aspects are measured in what we call a pulmonary function test. That's kind of a global response, and then you have three entities under that. Number one is spirometry. Spirometry looks at two things. Number one, it looks at flow of gases through the tracheobronchial tree or into the lungs. So it looks at flow of gases. And number two, it looks at the volume of gases. So they're often compared to each other. So when we look at spirometry, we look at flow in relationship to volume. And we're going to talk about this more, but obstructive lung disease has more problems with flow, and restrictive lung disease has more problems with volume. So when we look at the two, and there are spirometry values, usually the flow values for obstructive diseases are lower, and the volume values for restrictive diseases are lower. So again, we're looking at two things, flow versus volume and spirometry. The second aspect of a pulmonary function test looks at the lung volumes. We all studied lung volumes and capacities. So you're going to be able to see the various lung volumes, vital capacity, total lung capacity, tidal volumes, FRC, those kinds of things will be able to be determined by a pulmonary function test. And then the third entity that's covered under a pulmonary function test is gas transfer. And we're talking about gas transfer across the alveolar capillary membrane. So we're talking about oxygen from the lungs into the pulmonary capillary, carbon dioxide from the pulmonary capillary into the lung. So we look at gas transfer across that alveolar capillary membrane, and that's going to determine various types of disease processes. So basically there are three indications for use of pulmonary function tests. One is diagnostic, so this is for diagnostic purposes. Patients often come to the physician and they have various signs and symptoms. One of the most common symptoms that a patient has is going to be dyspnea. So patients are going to come in, they're going to have trouble breathing. Sometimes they have dyspnea on exertion when they have physical activity, or sometimes it's just plain dyspnea when they're sitting. So this is probably the most common symptom that a patient comes into, which gives an indication to say, well, let's do some pulmonary function tests on this particular patient to see why they're dyspneic. Patients often come in with wheezing. Again, wheezing can be an early sign of asthma, so often the physician will order a pulmonary function test to determine the extent of the wheezing and where is this wheezing coming from. Is it due to some kind of intrinsic asthma, or can it be other types of obstructive diseases that are making this patient wheeze? Often these patients have a productive cough. They have a lot of mucus production. We're going to talk about chronic bronchitis patients. Those are the patients that have a lot of mucus production. So if somebody's coming in with this excessive mucus, it might be nice to determine, well, is this a type of a bronchitic patient? So again, they will get pulmonary function studies on these particular patients to make a diagnosis. And because, there's so much going on with lungs and wheezing and whatnot, these patients have accompanying chest pain that might not be cardiac related. It's probably due to some physical pain from excessive coughing or pain in trying to move volumes of gases in and out of the lungs. So those are some of the symptoms that you may see. Often when there's a physical assessment done on this patient, they have decreased breath sounds, usually in their lower lungs. They will have decreased breath sounds. On chest x-ray, they may see an overinflation of the lungs. What happens is in obstructive diseases, there's gas trapping. So they can't get the gases out. So what happens is the alveoli kind of balloon out, and they get this big overinflation of the lungs, which are seen on chest x-ray. Obstructive patients, again, they can't get the gas out, so there's a lot of expiratory slowing, which means it takes a longer time for them to exhale. So their IE ratios might be 1 to 3, 1 to 4, where in a normal patient we usually are in a 1 to 2 IE ratio. So they may have a lot of slower on expiration. They may have accompanying cyanosis if they have trouble getting oxygen in. So they may have accompanying cyanosis. There may be some chest deformity. Obstructive patients have what they call a big barrel chest because they have overinflation of their alveoli, so their chest kind of barrels out to accompany that hyperinflated alveoli. Some accompanying lab tests, if the patient's hypoxic, again, they may be hypercapnic. They can't get a lot of gas out, so there's a lot of trapping, which means that they're retaining a lot of CO2. In response to the hypoxemia, they may be polycythemic. Because of the fact that they have hypoxia, there's low oxygen saturation in the blood. The body wants to compensate by giving them more hemoglobin for them to carry this low amount of oxygen. They kind of compensate by giving them more hemoglobin. And again, if they have an abnormal chest x-ray, it's a good indication to get some of these lab values. So they often have accompanying lab values plus an arterial blood gas. So when you go to the pulmonary function testing center, these patients often have arterial blood gases drawn to determine the extent of the pathology. So we talked about some signs and symptoms. Pulmonary function studies are often done to screen individuals at risk of having pulmonary diseases. Someone who's a heavy smoker, and when we talk about heavy smokers, we're talking about a 10 to 20 pack year history of smoking. These are the patients that have a good indication that they may need pulmonary function studies to see if there's what's the extent of the smoking that had deleterious effects on the lungs. Patients with occupations that have a lot of inhaled substances that may injure the lungs, such as asbestos. Contractors or people that are working on buildings or destruction of buildings may be exposed to asbestos. Bakers in a bakery are often exposed to a lot of flour, and they can have problems with their lungs, especially chronic exposure to that in and of itself. You want to assess a preoperative risk. Obviously, these patients are going to be coming to you, so if they have a history of pulmonary problems, you want to know what the extent of the injury is so you can plan your anesthetic. Maybe you might not want to put these patients to sleep in a general anesthetic, and if they can have a regional anesthetic, you will avoid all of the manipulation of the lungs and ventilatory things that can be affected under a general anesthetic. So if they have a preoperative risk, there may be some other alternatives that you can use to avoid having any kind of ventilatory problems. Often done to assess prognosis of a patient, lung transplant, cardiac patients, they all have pulmonary function studies done to make sure that their lungs are working correctly, and this will determine the prognosis of their course and their treatment. And the last one is to assess the health status before enrollment in strenuous physical activity. A lot of times patients that are going to be in Ironman competitions or running marathons will have pulmonary function studies done to make sure that they are able to handle the rigors of those particular exercises. So the second indication for a pulmonary function study is for monitoring purposes. Patients that come in and have been diagnosed with asthma, they will have bronchodilator therapy. So what the pulmonary function study does is before the patient is administered a bronchodilator, they get a pulmonary function study done to determine, what the extent of the damage is, why they need those bronchodilators. Then they will give the patient a bronchodilator, and they will assess the effectiveness of the bronchodilator. So the rule of thumb is there should be an increase of 15% in lung functions after bronchodilator therapy. That's what determines a successful bronchodilator, is if they have a 15% increase in their lung function after the bronchodilator. That's a good indication that bronchodilator is going to work. So patients that are coming in with asthma that need to be put on a bronchodilator, they often have pulmonary function studies as well. Patients that have treatment for asthma or interstitial lung disease, and we're talking about chronic steroid use. So these patients will have either PO steroids or inhaled steroids. They will come back periodically to determine the extent that steroid has actually worked, because obviously chronic steroids can be harmful to a patient, so they want to see what the extent is of this steroid therapy, hopefully wean them off. So they will come back for pulmonary studies as well. Patients that are on antibiotics and cystic fibrosis, again, they want to assess, the physicians want to assess the antibiotics and the course of the antibiotics to see if they're effectively treating that particular disease. And then the last one is to monitor any adverse reaction to drugs with known pulmonary toxicity. Bleomycin is a chemotherapeutic agent that has deleterious effects on the lungs. So patients that are on chronic bleomycin therapy will come back for pulmonary function studies. All the patients that you're going to see in the heart room that were on amiodarone can have toxic effects on the body. So those patients, again, post-cardiac surgery, will come back to determine if they had any kind of lung damage from that particular use of that particular drug. And the last indication for pulmonary function studies, more of to assess disability patients, any kind of impairment evaluations. So this is part of a rehab program, again, to determine the extent of the pulmonary function study or lung values in pulmonary function studies as well. Some contraindications for the use of pulmonary function testing. Number one is hemoptysis. That's probably the primary one, is hemoptysis. Well, we're going to talk about pulmonary function studies that we're going to see patients. They're going to take. They're going to be using a spirometer, and these patients are going to tell them to take a big, deep breath in, as big as possible. Then they're going to tell them to blow this volume out of their lungs as quickly and as fast as possible. So it takes a lot of effort. So there's a lot of effort when these patients blow out into this spirometer. So any kind of hemoptysis, you don't know where that's coming from, and you don't want to exacerbate that to cause any additional bleeding, because the pulmonary function tests are very, very active, and it's not as simple just to breathe in and breathe out. I mean, they tell these patients to take big, deep breaths out and blow out as hard and as fast as possible. So you don't want any kind of hemoptysis because that can further exacerbate bleeding. Anybody that has a history of a current pneumothorax, because the pulmonary function test can create a tension pneumothorax. Unstable angina, again, we're talking about a lot of effort, so you don't want to create any kind of further angina that can lead to an MI. Anybody who has a recent MI. Anybody who has any type of aneurysms, again, because we're talking about use of force in your expiration, inspiration, you don't want to have possibility of dissecting or rupturing an aneurysm. Anybody has recent eye injury, you don't want any increased intraocular pressure during this forced expiration because then they can develop a ruptured globe. Any kind of recent abdominal or thoracic surgery procedures, again, you don't want them to dehiss, again, so, because there's a use of a lot of force. And the last one, if you ever go to a pulmonary function testing site in the facility, you're going to see patients will often faint because there's a lot of forced expiration, and some of them are very, very weak, so they often faint. So anybody who has a history of syncope, you want to be really, really careful with them because, again, we're talking about a lot of effort in these pulmonary functions tests, and there's a lot of increased intrathoracic pressure and lung volumes and whatnot. So you have to be really careful with these particular studies. So let's look at the use of spirometry. So when we're looking at spirometry, we're again measuring flow and measuring volume. So you can see in the photo on the right, the woman at the extreme right is obviously is a respiratory therapist or a physician, and the patient is on the left, and you can see that she has a simple spirometer in her mouth, and she's going to be inhaling in and out of that spirometer to look at spirometry values. Again, looking at flow, looking at volume, and you can see that she has a nose clip on her nose because we don't want any air or any gas to be escaping through the nose. We want to assess what is going in and out of the lungs. So number one, they have to create a nice tight mouth seal around the mouthpiece. And number two, the nose has to be pinched off because all the gas that goes in and out of the lungs has to be measured. We can't escape it through the mouthpiece or can't escape it through the nose clip. So what is spirometry? Again, we talked about this. Spirometry is a measure of airflow and lung volumes during a forced expiratory maneuver from a full inspiration. So it is a measure of flow and volume during a forced expiratory maneuver from full inspiration. So this patient, again, is going to take a very deep breath in, and she's in that mouthpiece, she's going to blow out as quickly and as forcefully as possible. So again, they take the biggest deep breath in that they can, and the therapist will tell them to blow it out as quickly and as forcefully as possible. And I'm going to show you a little video at the end of the lecture so you can actually see these pulmonary function tests in action. So how do we do it? Again, the patient's going to stand, but they usually sit. They sit upright, and the patient places a nose clip over their nose. They will inhale maximally. They get a really good seal around the mouthpiece, and they blow out as hard and as fast as possible for 6 seconds. So that's kind of the standard, or the gold standard, is to blow out into the mouthpiece for about 6 seconds. And therapists will usually have them do this about 3 times, and they record the best of 3. And if the patient's on a bronchodilator, they should hold the bronchodilator, and again, it says for a few hours, but it should be for 8 hours before the test. So anybody who's on a bronchodilator, they need to assess the actual values without the bronchodilator therapy. So they usually will hold that for about 8 hours. Acceptable criteria. A patient can't cough or hold their breath, close their glottis during the first second of exhalation. So they can't, if they start coughing, again, that is grounds for dismissal of that pulmonary function test. Or they can't hold their breath during that first second of exhalation. Any kind of early termination or cutoff, we said that the patient needs to blow out as hard and as fast as possible for 6 seconds. If they don't last for 6 seconds, then again, that pulmonary function study is negated. Variable effort, again, this spirometry is effort dependent. The first part we're going to talk about this is effort dependent. So when the therapist tells the patient to blow out as quickly and as hard as possible, there's a lot of effort on that patient to do that. And some patients may be very weak, that they can't do it, so they don't have a lot of effort to do it. Some, again, due to the nature of their pathology, will start to cough, so they, again, there's a lot of effort that's involved, and there can't be any variability in it. They have to be able to blow out as quickly and as hard as possible for 6 seconds. You can't have a leak around the mouthpiece. There can't be any obstruction in the mouthpiece, such as excessive mucus, where sometimes patients they'll push their tongue against the mouthpiece. You have to have good starts, so you have to have the patient breathe in as deep as possible and exhale as deep as possible. So good starts meaning taking that big deep breath and again have that satisfactory exhalation for about 6 seconds. So when we look at the pulmonary function tests, what's going to happen is that you're going to see a graphic picture of this. So you're going to see a graphic picture being taken when this patient does this spirometry. So you can see that there's coordinates. There's a flow, vertical flow coordinate, and a horizontal volume coordinate. So we're talking about a flow volume loop. So these are examples of a flow volume loop. We're going to look at flow because spirometry measured flow, and we look at volume, which measures volume as well. So the flow volume loop, which is this, graphically demonstrates the flow generated during a forced expiratory maneuver plotted against the volume coordinate. So it looks at flow and volume during that forced expiration. So anything that's going to be below the horizontal line is the inspiration. So the patient's going to inhale, and you're going to see a graphic representation of the inhalation. Then the patient exhales. Again, it looks at flow and it looks at volume for about 6 seconds. So this flow volume loop is a normal flow volume loop. So you can see that the patient exhales, and they should be able to exhale about 80% of their volume during the first second. So they should exhale about 80% of their volume during the first second. So there's a huge sharp uprise in flow, and then there's a gradual descent until 6 seconds is reached. So that is a normal flow volume loop. We said that these flow volume loops need to be free of any kind of artifact. So again, you can see in the bottom left, patient inhales as fully as they can, and when they start to exhale, they start to cough. So again, they have to be free from any kind of coughing, because this is going to distort the actual flow volume loop, because pictorially this is going to give us an indication of the disease process. And we're looking at obstructive patterns versus restrictive patterns, which we're going to talk about. Somebody has poor effort. You can see they haven't taken a very big deep breath in, so obviously they're not going to take a very deep breath out. So this is very poor effort. This is a patient that's breath holding, so again, this is going to give you a very different pattern. So this is the classic pattern that you want to see during spirometry. So during spirometry, two things are measured. Number one, volume time graph loops. So you're going to see a volume, the amount of volume that the patient exhales, and the amount of time it takes for that patient to exhale that volume. Now, in a normal patient, the patient should be able to exhale 80% of their volume at 1 second. That's a normal patient is able to exhale 80% of their volume in 1 second. And we're talking about forcefully. So we're talking about a big, deep breath in and blow it out as quickly and as fast as possible. So when they do that, in 1 second, 80% of that volume should already be out of their lungs. And we call that the FEV1, or forced expiratory volume at 1 second. And this is going to give a key indication. This particular volume here gives us a key indication in looking at someone and diagnosing someone who is in a obstructive versus a restrictive pattern. So again, in this patient, they've exhaled 80% in the first second, and again, by 3 seconds to 4 seconds, they should have pretty much exhaled most of their lung volume, and they give them up to 6 seconds. So it looks at how much volume exhaled over a period of time, specifically at 1 second, and then it's 6 seconds. So that's the first thing we monitor during a simple spirometry. The second one we already talked about is the flow volume loop. How much volume they get out, how much flow they get out, and how much volume that they get out. And this one is a classic example of a normal flow volume loop. Again, inspiratory till capacity, then blow it out as quickly as possible. So they get a lot of good flow out, and the flow continues to decrease to volume. So this is a classic pattern of a pulmonary function test. Again, the volume time graph, we just talked about this. The FEV1, 80% needs to be exhaled in about 1 second. About 3 to 4 seconds, again, they should be getting pretty much emptying their lungs. About 95, 96, 97% should be exhaled at 4 seconds, and again at 6 seconds. Everything should go to residual volume, which means that everything is out of the lungs at that particular time. So we're looking at different factors when we look at simple spirometry. Number one, we're looking at the forced vital capacity. Forced vital capacity. Forced vital capacity simply means the amount of volume that is exhaled from the lungs during a forced expiration at 6 seconds. So you can see from the previous slide, a forced vital capacity will be the amount of volume that is exhaled all the way to the end of 6 seconds till the patient can't exhale anymore. That's called the forced vital capacity. So it's the amount of volume that is exhaled as forcefully as possible in 6 seconds. And this is going to be calculated. We're going to talk about how these things are calculated. So that looks at the forced vital capacity. FEV1 is simply the amount of volume that's forcefully exhaled at 1 second. So you're going to have a value for the forced vital capacity, and at 1 second, 80% of that forced vital capacity should be exhaled. So we look at the ratio, which means that a patient at 1 second will blow out X amount of gas, and in relationship to the forced vital capacity. So this should be 80% of the forced vital capacity, which will give you the percentage of 80%. Anything less than 80% is considered some type of pathology. So again, that's going to look at a diagnostic to say, well, the FEV1 in relationship to the forced vital capacity is 60%, so that's an indication that there's a problem with some type of disease process that's going on into the lungs. So these three things, the forced vital capacity, the forced expiratory volume, and the relationship between the two, look at volumes. So we're assessing volumes in the first three. We're assessing volumes in the first three. These depend on effort. how quickly the patient can exhale that in 6 seconds, and how forcefully they can exhale that in 6 seconds. So these depend on effort, and they all look at volumes. The last two things that are measured in spirometry are independent of effort. So these two things are independent of effort, and they look at flow. So forced expiratory flow, 25%, forced expiratory flow at 75%. So flow is going to give you an indication that there is a problem with the lungs. So the flow at 25% of that volume should be exhaled, and at 75% should be exhaled. So we're looking at flows, and patients that have a problem with flow indicate an obstructive disease. And patients that have a problem with volume have a problem with restrictive disease. So if a patient has a normal forced vital capacity and their forced expiratory volume in relationship to that forced vital capacity is 80%, however, their flow rates are decreased, that's an indication of an obstructive pattern. A restrictive pattern will have normal flows, but will have difficulty with volume. So in spirometry, we're able to determine that if there's a decrease in volume, decrease in any of the first three, it's usually an indication of a restrictive disease. If there's a decrease in flows, there's usually an indication of an obstructive disease. So these 5 coordinates are going to be able to tell the provider if it's a problem with flow, that equals obstruction. If there's a problem with volume, that equals restrictive disease. We already talked about this. The forced vital capacity is the total amount of air expired as quickly as possible after taking the deepest breath possible, and this is usually done over a 6-second period. FEV1 is the volume of air which can be forcefully exhaled from the lungs in the first second of the forced expiratory maneuver. So this is the amount of air that's forcefully exhaled from the lungs in the first second of the forced vital capacity, and that should be 80%. And again, the ratio is the percentage of the FEV1 to the forced vital capacity. And again, we talked about that being approximately 80% is the cutoff. FEF 25, FEF 75 is the amount of air that was forcefully exhaled in the first 25% of the total forced vital capacity. And the FEF 75 is the amount of air expelled from the lungs during the first 75% of the forced vital capacity. So between 25% of that forced vital capacity and 75%, that's going to give us an indication of the amount of air that's being exhaled, and it usually has an indication of a flow problem. So we said that this is independent of effort. The patient has no control over this. The patient has control over the forced vital capacity because we're telling them to blow out as quickly and as hard as possible. We do that in the first second. But after the first second and the next 25 to 75% of that forced vital capacity, the patient has no control over that. So that's giving us more an indication of a flow value. And that's going to give us the indication versus obstructive versus restrictive pattern. So the general rule of thumb is that your FEV1 should be 80% or greater of what your predicted value. That is considered normal. If the FEV1 is between 60 and 80% of predicted, it is a mild disorder. If the FEV1 is 40 to 60, it's considered a moderate disorder. And if it's less than 40%, there's a severe disorder. So again, if your FEV1, which is volume, is going to be less than 80%, it's giving us an indication that there's a problem with the lungs. So the cardinal feature is the FEV1 FVC ratio, and if it's less than, and we're saying 80, not 70, 80 is considered an obstructive disease. So what are the predictors? We talk about 80% of predicted. Well, the predicted is going to be based on a multitude of factors. Number one, it's based on age. Your forced vital capacity and your flow rates decrease with age, especially anyone older than 35 years of age. After that, your vital capacities and your flow rates start to decline. Height, usually the taller that you are, the increased number of alveoli and the size of your lungs. So their measurements are going to be patients that are taller have more volumes and evidently more flow rates than someone who is a shorter stature. Gender, pulmonary function values are lower in females than males. Weight is kind of a tricky one because the bigger you are, the higher your pulmonary function values are until you get to a certain weight, which is considered obese or morbidly obese. And patients that have morbid obesity, their pulmonary function values are going to decrease because of all this weight impinging upon the lungs. So their lung volumes and capacities are going to be lower because of this abdominal girth impending on their lungs. So again, the predictors: age. Again, the older you are, the decrease or lower your pulmonary function values are. Height, the taller you are, the higher your pulmonary function values are. Gender, males usually have greater pulmonary function values than females. Weight, again, the more weight you have, generally, the higher your pulmonary function values until you get to morbidly obesity, and then your values decrease. And the last one that's not on here is ethnicity. So you're going to see on a pulmonary function study, they're going to have the patient's height, weight, their gender, their age, and they're also going to have their ethnicity because different ethnic groups have different lung volumes. Caucasians have higher lung volumes than African Americans and Asian population. So Caucasians, if you're looking at their predicted values, they may be higher than someone who is African American or someone who is Asian, because again, we're always looking at what is predicted. Is there FEV1 80% of predicted based on gender, age, height, weight, and ethnicity? That's our predicted value. They're going to get an actual value, what they're actually blowing out, and we compare that to their predicted value. And if it's 80% of what their predicted value is, then it's okay. But if it's less than that, then there's going to be a problem with the pulmonary function study itself. So the next thing we're going to look at is what we determine flow volume loops. And again, this is done during simple spirometry, and this is a pictorial representation of your forced vital capacity and FEV. So if we look at a flow volume loop, it's the plot of the inspiratory and expiratory flow against a volume during a performance of maximally forced inspiratory and expiratory maneuvers. So again, you have the patient take a deep breath in as hard as possible, inhale as much as possible, then they blow it all out as quickly and forcefully as they can in 6 seconds. So it looks at the flow of that gas through the tracheobronchial tree and the volume that is exhaled during that forced maneuver. So it looks at the volume, forced vital capacity, and it looks at flow. It's the contour of the loop. This is very important. It's the contour of the loop that assists the diagnosis and localization of the airway obstruction in different lung disorders, and that they produce a distinct, easily recognized pattern. So different diseases are going to change this pattern. This is a normal pattern. Again, you can see that they take a deep inspiration and forcefully exit out as quickly as possible, so you get a sharp uprise and a kind of a sharp decrease, although it's gradual decrease in volume. So that's a normal flow volume loop. Again, you can see on the right, this is a normal flow volume loop. When we look at someone who has an obstructive pattern, we're going to be talking about emphysemic patients versus obstructive patient. They have what's called a dog leg pattern. So they have a dog leg pattern. The dotted line represents what is predicted. So this should be their predicted values, again, based on age, height, weight, ethnicity, gender. So that's what is predicted. You can see this patient is able to take a deep breath in, and then they're able to exit the air. They're able to exhale, but look what happens to the flow. The flow generally peaks and then it drops off sharply. It drops off sharply, and then they eventually get the volume out. This is a classic pattern of obstructive disease called the dog leg pattern, because it looks like kind of a leg of a dog. You can see that this is the leg and then this is the foot right here. So they call it a dog leg pattern. And again, obstructive diseases have a problem with flow, not volume. You can see that this patient can get the volume out. So this is the volume coordinate. They're able to get the volume out. But look what happens to their flow. Their flow sharply decreases. Again, you can see that the flow gradually decreases in what is predicted, but in this one, the flow actually sharply decreases. So this pattern is what you need to know. This is an indication of an obstructive disease pattern. So that's your classic obstructive disease pattern, is that dog leg pattern. Again, we already talked about this is a normal flow volume loop. Again, this one indicates poor effort, coughing, stopping too soon. Again, so we need to have a patient have great effort. They can't cough. They can't hold their breath. Again, you've got to have good starts, which means a good inspiration to capacity and blow out as quickly and as forcefully as possible. So again, our flow volume loops are going to give us a graphic indication of a pulmonary pathology. And the pulmonary function test and spirometry are going to determine whether this is an obstructive pattern versus a restrictive pattern of disease. So when we look at obstructive lung diseases, and you're going to have more in subsequent lectures on obstructive lung diseases. Obstructive lung diseases, again, mean a problem with flow, not volume. These patients can get the volume out, and it may take a lot longer to exhale, but they have a problem with flow. Common obstructive lung diseases, are chronic obstructive pulmonary diseases. Chronic bronchitis versus emphysemic. Usually there's an overlap between these two. COPD, this is on a continuum. One extreme are chronic bronchitis. We often refer to these patients as a blue bloater, which means that they have often a lot of bronchitis, which means they have a lot of mucus production. They are often cyanotic. So we call them a blue bloater because they're blue, they're cyanotic. Usually these are very heavy-set people, and they obstruct because of the fact they have a lot of mucus production, again, from smoking or chronic environmental factors. The other end of the spectrum is emphysemic patients. We call these people the pink puffers because all they do is breathe. They kind of purse lip breathe really, really quick. You'll see them sitting up in the chair. They're usually really, really thin, and they're sitting in the chair and they purse lip breathing. And they're breathing pretty rapidly. They're pink because they're effectively ventilating, but all they're doing in life is just breathing really, really quick, and they're purse lip breathing to keep all that alveoli open, and we call them the pink puffers, and these are the blue bloaters. Usually there's a cross between the two. Sometimes, most often, patients aren't just one or the other. There's also a cross between the two. So those are your classic COPD patients. And then an offset of COPD is the asthmatic patient. So we look at a flow volume loop and an obstructive lung disease. So if we look at asthma, asthma is kind of one of those entities that are out there. They're really not an obstructive pattern because of the fact that they can be, so to speak, cured, or they can be improved by use of a bronchodilator therapy. Usually some obstructive lung diseases, if they're far along, there's nothing that can be done to really correct the problem. But asthma is usually corrected. So you can see that this is the normal pattern of a pulmonary function test or a flow volume loop. Someone who has asthma, the outer dotted line is what is predicted. So this is the one that is predicted, and again, that's based on gender, height, weight, ethnicity, those kinds of things. The pulmonary function test is what they're going to do is they're going to look at pre and post treatment. And after a bronchodilator treatment, the patient should improve about 15%. So this is what is predicted at 15% of the bronchodilator therapy. This is pre-treatment. So you're a patient that has an asthmatic patient, and this is what you get. You take a deep breath in as quickly as possible, and you can see they kind of get that dog leg pattern where they get that sharp drop and then the longer expiration. So this is what is pre-bronchodilator therapy, and if the bronchodilator is effective, this is what they should get post-treatment. So they're comparing what they look like pre and what they look like post. And if in the post-treatment we don't get this pattern, that means that the bronchodilator wasn't effective. So they may need to increase the dose or change the bronchodilator itself. So again, this is a classic pattern of an obstructive patient in asthma. This is your classic emphysemic patient. Again, you can see that the airways collapse during a forced expiration. And if we look at a kind of a picture of that, and we see that in an obstructive pattern. This is a terminal bronchial, and this is the alveoli. So what's going to happen is in a patient who has some kind of obstructive lung disease, they have destruction of their bronchial walls. This is a terminal bronchial. And they have destruction of the walls that lead to the alveoli. So when we do a pulmonary function test, and we're looking at spirometry, and we're telling the patient to blow out as quickly and as forcefully as possible. And once the patient does that, there's a positive intrathoracic pressure because the patient is now blowing out as quickly and as forcefully as possible. So what happens is in a normal patient, these walls hold up to that force expiration, so they don't collapse. In someone who has a destructive lung disease, what happens is the airways become so much narrower because they tend to collapse. So then there's a lot of gas trapping. They can't get the air out as quickly as possible because there's a lot of air left behind because the walls kind of cave in. So their FEV1 might be less than 80% of what is predicted because of the fact they have this trapped gas that's in here. So that is why you see that during the forced expiratory rate, their flow decreases because, again, they have this trapped gas in their alveoli. So this creates a lot of turbulent flow here. So they can't get the flow out or the volume out as quickly as possible because of the fact that this airway is narrow. So this becomes turbulent flow. So therefore, you see that flow rate quickly drop off to that dogleg pattern because they can't get that flow out. Eventually, if you give them enough time, they're able to get all of this volume out. It may be even greater than 6 seconds, but they're able to get it all out. If you give them time, this volume will eventually come out. So they don't have a problem with volume. They, meaning the obstructive diseases, don't have a problem with volume because eventually they can get it all out. What they have a problem with is flow because, again, that creates all that turbulent flow. That's why you get the quick decrease in the flow. So this is your flow coordinate. I don't know why I'm writing sideways. Your flow coordinate, and this is the volume coordinate. So you can see the flow quickly drops off. So that's why you get that dogleg pattern. Again, they can get the volume out eventually, but the flow is the one that's going to decrease. So that is your classic flow-volume loop in someone who has an obstructive lung disease. And emphysema, bronchitis are considered obstructive lung diseases. We talked about having the ability of reversibility, and especially in the asthma patient, if the bronchodilator improves your FEV1 by 12 to 15%, then the bronchodilator therapy is effective. And someone who has an asthmatic, their disease is reversible. So that's a characteristic of asthma, is the reversibility of the disease with the use of a bronchodilator. So again, if they improve their FEV1 by 15%, then the bronchodilator was effective. And that's what then they will then be placed on that bronchodilator based on this pulmonary function study. So the asthmatic patient comes in, they have a problem with wheezing, they give them a bronchodilator, and that is effective in creating 15% of that forced expiratory volume. Then they know that bronchodilator was effective, and they will place that patient on that bronchodilator therapy. So it's the reversibility of it, which is a cardinal feature of asthma. We're going to skip this slide right now, and then we're going to go on to restrictive lung disease. Looking at restrictive lung disease, we said that obstructive lung disease, there's a problem with getting the flow out. They have a breakdown in their terminal bronchiole, which traps all that excess gas, and they have turbulent flow. So they have a problem with flow, but they eventually can get the volume out if you give them long enough to do that. In restrictive lung disease, they can't get the volume in and out. They don't have a problem with flow, but they can't get the volume in and out. So in restrictive lung disease, there's more of a problem with volume. And there are 3 types of restrictive lung diseases. Number one, there's what we call an intrinsic restrictive lung disorder. And this usually has to do with lung tissue. So the intrinsic restrictive lung disease has to do with the lung tissue. The actual tissue is destroyed and it's hardened, where they can't get full expansion, excursion of their lungs, so their elasticity is decreased. They're more like very hard lungs. They can't, they have decreased compliance, decreased elasticity due to some kind of an insult. They can be due to sarcoidosis. The most common of the restrictive lung disease is pulmonary fibrosis. So these are the patients that were chronically exposed to asbestos. Asbestos destroyed the lung tissue and created a lot of scar tissue. The scar tissue made the lungs very, very stiff. So if you have stiff lungs, you can't get air in or out. They can't breathe in effectively, and they can't get obviously that volume out because they can't breathe they can't get the air into the lungs. Any kind of interstitial pneumonitis, any kind of a viral infection that can create an inflammation of the lungs, again, they have a problem with getting air in and out. TB patients, because they have these little pockets of tuberculosis disease, make the lungs very, very stiff. A pneumonectomy, loss of a lung, the one lung tries to compensate for it but may not compensate effectively. Pneumonias are considered a restrictive lung disease. And pneumonia is usually a temporary type of thing, where pulmonary fibrosis is usually a chronic condition. Again, pneumonias are usually kind of an acute kind of condition, but again, they're considered a restrictive lung disease because there's a problem with the lung tissue itself. The second type is extrinsic. This usually has to do with something outside of the lung tissue. The lung tissues are usually normal. These ones usually have to do with the bony structure. So we're talking about any kind of kyphosis or scoliosis. Someone has a curvature of their back, usually will affect the lungs, especially the curve where the curve is may constrict one part of the lung and then overinflate the other part of the lung. So these are restrictive. Ankylosing spondylitis, again, is more of a bony structure of the condition of the ribs, again, making it impossible for the lungs to fully expand because the bony structure is creating a restriction so the lungs can't fully expand. Pleural effusion, any kind of pleural effusion, again, is going to, it's outside of that lung itself, is going to create an extrinsic condition. Pregnancy, again, just the sheer fact that the baby's pressing on the lungs is considered a restrictive disease. Anybody who's morbidly obese, which we talked about, any kind of tumors on the lungs that would create on the lungs or in and around the belly that would create full expansion of the lungs, or prevent full expansion of the lungs, is a restrictive disease. Ascites, liver patients are going to have big bellies, again, kind of like pregnancy, where they impinge upon the lungs itself. And pain. Anybody that has rib fractures or pleurisy or maybe a very large abdominal incision, they're going to have a restrictive pattern disease as well. So we talked about intrinsic means on the lung tissue itself. Extrinsic is outside of the lung tissue. And then anybody who has a neuromuscular disease, patients that have myasthenia gravis, ALS, MS, that any type of disease that may affect the neuromuscular transmissions, that may affect the diaphragm or any kind of muscles to the lungs, again, is going to be called a restrictive disease. So we talked about intrinsic, the lung itself; extrinsic, usually the bony structure or something outside of the thorax that's impinging upon the lungs, or any kind of neuromuscular disease itself. So we said that the restrictive disease usually has a problem with volume. We said obstruction has a problem with flow. The restrictive has a problem with volume. So you can see that full expansion of the lung is limited, and therefore the forced vital capacity is reduced. So which means that they can't, these patients can't take in a big deep breath because they can't get the air in. The lungs are stiff. Something is impinging upon that bony structure. They have a neuromuscular disease where they can't really take a deep breath in. So obviously their volumes are going to be decreased. So their forced vital capacity is going to be decreased. Again, because of the fact that they can't take a deep breath in, their forced expiratory volume at 1 second is going to be decreased because they have a problem with volume. But if you look at the ratio between the two, since both are low to begin with, then their FEV1 to FVC will be normal. It's usually normal. So when we look at this, we see the pattern. We have forced vital capacity is low. It's lower than what is predicted. Their FEV1 is lower than what was predicted because they can't get the volume out. But if you look at the ratio, their ratios are usually normal because both of these are low. So if the rule of thumb is if we expect a restrictive pattern, if we look at these two things, then we have to look at their lung capacities and lung volumes, which we're going to talk about, because they should all be decreased. So if these two are low, but their ratio is normal, then we have to look at their capacities and volumes, which we're going to talk about. Flow volume loops in a restrictive lung disease. This one on the bottom is your classic. So this is your classic pattern here, is that they can't get the volume in and they can't get the volume out. So you can see that this is what is predicted and this is what they actually get. So this is your actual classic pattern of a restrictive lung disease. This is neuromuscular weakness. Again, you can see the problem with volume. So again, the obstructive patient can get the volume out, but they have a problem with flow, so we have this sharp decrease. These patients don't have a problem with flow. You don't see that sharp decrease, that dogleg pattern in any one of these, but they can't get the volume out. So they can't get this volume out, and this is the volume coordinate. So again, this, for exam purposes, this would be more of an obstructive. These two would be more of the restrictive because they can't get the volume in or out. So again, these pictorial, looking at these pictures of flow volume loops gives you an indication of which one's obstructive and which one's restrictive. So if you gather anything from this whole thing, in an obstructive pattern, your FEV1 will be reduced because of the fact that during this forced expiratory volume, so again, if you look at your obstructive versus restrictive defects, obstruction, their FEV1 is going to be decreased because they have a difficult time getting that volume out in 1 second because, again, of this. We're looking at the fact that during the forced expiration, the walls collapse. So all that volume that's in here becomes trapped. So at 1 second, it's usually less than 80% of predicted. So again, their FEV1 is going to be decreased. But they're able to get the forced vital capacity out. If you give them 6 seconds, 8 seconds, they're able to get that out. So the ratio between the two is going to be decreased. So again, if you look at this chart, and this is what you really need to know if you anything, is that for obstructive, their FEV1 is going to be decreased because they can't get that volume out at 1 second because of that air trapping. Eventually, they get it out. So again, their FVC is normal, and their FEV1 to FVC is reduced. So that's usually less than 80%. In someone who is restricted, we said that they can't get the volumes in, so they can't get the volumes out. So if they have a decreased FEV1 and a decreased forced vital capacity, the ratio is going to be normal because these are both decreased. FEV1 isn't decreased and the FVC isn't normal. So again, the ratio will be normal between the two. Part 2 of the lecture on pulmonary function tests, we're going to look at the second and third type of pulmonary function tests. We said at the very beginning that there are 3 types of pulmonary function tests. Number 1 was spirometry, which we looked at flow versus volume. We looked at flow volume loops and time coordinates to actually look at a pictorial graphic representation to determine if a patient is obstructive versus restrictive disease. So the second part looks at lung volumes. We looked at spirometry. Again, we looked at flow versus volume. Now we're going to actually look at lung volumes, measuring the actual volumes of the lungs. Lung volumes are a good indication for someone who has an obstructive versus a restrictive disease. For purposes of this lecture, we're going to say that anybody who has a low forced vital capacity is usually a restrictive lung disease. Sometimes they can be an obstructive pattern. If they have extreme air trapping, they still can't get all of the air out at the forced vital capacity. But for purposes of our lecture, someone who has a low forced vital capacity is going to be more of a restrictive disease itself. Now, the pulmonary function studies are going to measure lung volumes and capacity. So when we're talking about lung volumes, we're really talking about lung volumes, and you should really add the word capacities to that. So we're going to look at lung volumes and capacities. There are 2 ways to measure lung volumes and capacities. The first type is more of an archaic type. They really don't use this anymore. They look at gas dilutional tests. The most common thing is they use a body plethysmograph or a body box. So this is what a body plethysmograph looks like, and you can see this is part of the pulmonary function testing in the Pulmonary Function Testing Center. They have, you saw the picture of the woman that was breathing through a mouthpiece. They actually can do that part in this body plethysmograph. They will keep this door open, and I have a video that you will see that the patient will actually breathe through this mouthpiece and take a deep breath in and blow it out as quickly and forcefully as possible, and that's what they're looking at in spirometry. That's what we're talking about, the flow volume loops. The body plethysmograph is this we call a body box, where the patient sits in this booth, and the door will be closed. So you can see that the patient sits inside a fully enclosed rigid box and breathes through a mouthpiece connected to a shutter to the internal of the box. So what they will do when they're measuring volumes and capacities, they close the door and make this airtight. When they're doing simple spirometry for the flow volume loops, the door remains open, and this will make a little bit better sense to you. So the patient will breathe through this mouthpiece, so they will close the door, and the subject makes respiratory efforts against the closed shutter like they pant. So what they're going to do, and you're going to see this in the video, they close the door and they tell the patient to breathe normal. So they'll take a couple of just normal breaths through this mouthpiece. And then they will tell the patient to start to pant. So you can see the patient will start to pant. They'll say, take quick, slow breaths through there, and then they pant. And then eventually they close the shutter. So the patient is actually panting against an obstruction. It's creating all this pressure in their lungs and pressure in this box, and that is how they determine the volumes and capacities due to the pressure in their lungs versus the pressure in the box. And this is based on Boyle's law in actuality, where pressure is inversely proportional to volume. So if there's greater pressure in their lungs and greater pressure in this box, then the volumes that they have breathe in and out and the capacities that they breathe in and out should be less. So again, this is based on the fact that this is on Boyle's law. So this has to be a tight seal because they're measuring pressure in the lungs and pressure in the lungs and volumes in the lungs and pressure in the box and volume in the box. The problem with this box, obviously, patients can get very claustrophobic. It's a very tight box. There's not a lot of airflow in there, so patients can get claustrophobic. A patient may not be able to enter the box. They may be in a wheelchair. They may be morbidly obese, and they can't actually enter the box itself. And one of the problems with the patient does is they can't pant effectively, because they tell the patient to breathe normally, and then they tell them to pant quickly as possible. And patients, at that point, when we talk about patients that pass out, this is when they usually pass out. This is because they can't pant effectively, or they just get it's too much effort, and they can actually pass out. So maybe they can't get into the box, maybe they're claustrophobic, or maybe they can't pant effectively in this box. And you can see that this is the patient. This is during their measuring their volumes and capacity. So they're sitting inside of the box, the door is closed, they have a nose clip on the patient, they tell the patient to get a tight seal around the mouthpiece, they tell them to put their hands on their cheeks, they breathe normally, then they tell them to pant really quick, and then they close the shutter, and once they close the shutter, all this pressure builds up in their mouth and in their lungs. And the pressure, again, inside of this box is going to change because, again, of the force that they're doing. So when they do that, they're able to measure lung volumes and capacities. Again, this is based on Boyle's law. If the pressure is high, then the volumes will be low. If the pressure is low, then the volumes will be high. So the more pressure they're panting against this closed shutter, and the more pressure that's created is going to give a bigger prediction that their lung volumes are going to be lower. So by using this technique, we're able to determine all of these capacities and all of these volumes. So these are the ones that were kind of traditionally learned in pulmonary physiology, all the normals and the abnormal values in their lung capacities and their volumes. So when we look at someone who needs to have a pulmonary function test, we looked at the first part, which is spirometry, looked at their flow versus volume. Did they have good flow but low volumes? Restrictive disease. Did they have poor flow but good volumes? Again, obstructive disease. Well, the second part they're going to look at are their volumes and capacities. Someone who has a restrictive disease is usually going to have a low volume and a low capacity, and someone who has an obstructive disease may have a normal or sometimes an increased volume. So we look at the residual volume. And residual volume simply means that it's the amount of air at the end of a maximum expiration. So the patient breathes in and breathes out as quickly as possible. And this is the amount of volume that's left in the lungs. So after a forced expiration, they can't blow out anymore. There's some volume that's still in the lungs, and that's called the residual volume. Residual volume is often increased in an obstructive disease, and this is what you need to know. I don't care if you know any of this. It's increase in obstructive disease and decrease in restrictive disease. So residual volume, again, because obstructive disease is a lot of air trapping, so they have a lot of still residual volume left in the lung. So it's going to be increased in obstructive disease and decrease in restrictive disease. Tidal volume. It's the amount of air that we breathe in and out as we're sitting here right now. It's just a normal tidal volume breath. Tidal volume is decreased in decreased in restrictive disease and is normal in obstructive disease. So the amount of air that we breathe in and out in tidal volume is normal in an obstructive disease pattern and a decrease in restrictive disease pattern. Total lung capacity simply means that the amount of air that we can breathe in and the amount of air that we can breathe out, which includes your residual volume. That is increase in obstructive disease because we have an increase in our residual volume, and total lung capacity includes your residual volume. So your total lung capacity is increase in obstructive disease and decrease in restrictive disease. Expiratory reserve volume is the maximum air that is exhaled from resting and expiratory level. So it's the amount of volume that's expired by active expiration. So you have a normal tidal volume, you blow out normally, and then the amount of air that you blow out is your expiratory reserve volume. Expiratory reserve volume is increased in obstructive disease and decreased in restrictive. Inspiratory reserve volume is the maximum amount of air that is inspired in excess of tidal volume. That is normal in obstructive disease and decrease in restrictive disease. Inspiratory capacity is the maximal volume air inspired from resting expiratory levels, so you blow all of your air out. It's the amount that you breathe in. That is normal in obstructive disease and decrease in restrictive disease. Your FRC, all of us know about FRC in anesthesia. It's the volume of air remaining in the lungs at the end of a resting expiration. In obstructive disease, because of air trapping, it's increased. So it's an increase in obstructive disease, decrease in restrictive. Our vital capacity is a volume of gas measured on complete expiration after complete inspiration, is normal to sometimes normal and can be increased in obstructive disease and is decreased in restrictive disease. This kind of gives you a kind of graph of the two, but if you just know what I just talked about in each of those volumes and capacities, you should be good. So basically, if you looked at all of the things that we just talked about, all of the volumes and capacities pretty much were decreased in restrictive disease, but obstructive disease, sometimes they're normal, sometimes they're increased based on their FRC or their residual volume with the air trapping. So that's the second part of the pulmonary function studies. Again, we looked at spirometry, flow versus volume. Then we looked at all of our volumes and capacities, and if those capacities and volumes were low, that usually meant that there was a restrictive component. If they are normal to increase, that means that there's usually an obstructive component, because we said obstruction has no problem with volume. The restrictive does have a problem with volumes and capacities. So the last component of the pulmonary function study is what we call gas transfer. And this is gas transfer across the alveolar capillary membrane. So if we look at, again, this is your terminal bronchial. This is your alveoli. So you have your terminal bronchial and your alveoli. Then you have your capillary. So this is your pulmonary capillary. So this is venous blood coming in, and then this is arterial blood. So we're looking at the gas transfer across this alveolar capillary membrane. So if this was the membrane here, we're looking at gas transfer from the lung into the capillary, the pulmonary capillary. So that's what we're looking at. Gas transfer across that alveolar capillary membrane. So the study that does this, it looks at the gas transfer, is called gas diffusion, DLCO. So this is called the diffusion limitation of carbon monoxide. This is the actual study that they use. So this is called the diffusion limitation of carbon monoxide. And so what they do, since carbon monoxide is extremely diffusible across the alveolar capillary membrane, they use some carbon dioxide to measure the amount of the actual membrane itself. So what they will do is they have what they call a DLCO single breath. The patient inhales a gas of carbon monoxide, helium, air. So they usually, what they will do is they have this machine, and you don't really need to know these numbers, but they use 0.3% carbon monoxide, So they use a very low amount of carbon monoxide. Obviously, you don't want to use a high percent since that can actually kill a patient. They use 0.3% methane gas. They use 21% oxygen and 78% nitrogen. So they use room air, 21% oxygen. They use 0.3 methane gas, 0.3 carbon monoxide. So they have the patient breathe normally. Then they have the patient inhale the gas as quickly as possible, all the way up to their inspiratory capacity. So they have them take a very large, deep breath of this mixture, and then they hold it for 10 seconds. And they exhale this in a gas analyzer. And once they exhale in the gas analyzer, they measure the amount of carbon monoxide that diffuses across the membrane. And they do a calculation for this. It's usually the total carbon monoxide used, which is the 0.3%, minus the amount returned. Then they calculate the amount that will remain in the residual volume that they can't blow out. A normal value for DLCO is 25 cc's of carbon monoxide that's transferred per minute across that alveolar capillary membrane. So they look at the amount that transfers across the membrane. The normal amount is 25 cc's of carbon monoxide per minute that transfers across that membrane. Some factors that will affect the transference of carbon monoxide against that membrane. Number one is your H&H. If you have a low hemoglobin, carbon monoxide has a high affinity for hemoglobin. So it competes with oxygen to bind to the hemoglobin molecule. If you have low H&H, the DLCO is going to be decreased because of the fact that there's not a lot then that can be decreased or can be attached to this hemoglobin molecule. So if there's low hemoglobin, not a lot can be transferred to that hemoglobin in the blood from the lungs, so the amount that they get back is going to be greater. So if you have a decrease in your H&H, your DLCO is going to be low. If you have an increase in your H&H, polycythemic patients, there's going to be a falsely high reading because of the fact that your hemoglobin is going to be plentiful, so it's going to be able to attach more of the carbon monoxide that is actually given. So a decrease in hemoglobin is going to decrease your DLCO. An increase in your hemoglobin is going to increase your DLCO. Carbon dioxide. An increase in your carbon dioxide increases your DLCO, and a decrease in your carbon dioxide decreases your DLCO. Patients in a supine position versus a sitting position. If somebody's in a supine position, again, you're going to impinge upon your lung capacities and volume. So if you do that, then the amount of carbon monoxide that can transfer across that membrane is going to be decreased because your abdominal contents are pushing on the lungs, so it's going to affect the amount that's going to be absorbed. So that's why they always have these patients in a sitting position. Breath hold time, again, you need to have a 10-second breath hold time. Anything less than that is going to affect your DLCO. So they want you to hold the breath for 10 seconds. So that's why they need to do that. Blood volume, if you have a decrease in blood volume, obviously there's a decrease in your blood cells, your hemoglobin. So again, a decrease in blood volume is going to decrease your DLCO. The conditions that there's usually a decrease in DLCO is pulmonary fibrosis, ARDS patients, pulmonary edema, and emphysema patients. And it's usually because of the fact that the membrane itself is usually affected. So if you look at this picture, and this is your alveolar capillary membrane here. And a normal alveolar capillary membrane is going to be very, very small. It's measured in nanograms. So it's very, very small. Your lungs basically pretty much come in contact with your pulmonary capillary. But in a condition that a patient that has pulmonary fibrosis, where the lung itself can have a lot of scar tissue, and I know this is an exaggerated version of this, but that alveolar capillary membrane can become very, very thick. So there's a larger distance between the alveoli and the capillary. Where you can see in this one there's a shorter distance, and usually fibrotic patients or someone who has any kind of pulmonary edema where this would all be filled up with water or scar tissue, your DLCO is going to be decreased. So you're going to be decreasing in your carbon dioxide that transfers across that membrane because that membrane's too thick. So again, that is another way, if we're looking at, we're looking at the different patients in this slide. So we're looking at the fibrotic patient or ARDS or pulmonary edema patient. These are usually the patients that, again, are more of a restrictive disease because their alveolar capillary membrane is pretty thick. So usually, and not all the time, but for the most part, restrictive lung disease has a decreased DLCO, and obstructive disease may or may not have a decrease in DLCO, depending on the severity of the disease. Sometimes they can, sometimes they can't have a DLCO, but usually the restrictive disease is going to have a decrease in their DLCO because of this reason. They have a thicker membrane between the lung and the capillary. So their pulmonary capillary membrane is thick. Now, we said this usually occurs in restrictive disease. So usually the patient that has restrictive lung disease have a decrease in DLCO. A patient that has obstructive disease may have a normal or decreased DLCO, depending on the severity of the disease. So this is obstructive. So again, it depends on the disease. And if you think about it, if this is your terminal bronchial, alveoli have a lot of surface area in them. So there's a lot of surface area in them to absorb, to transfer gases in and out of the pulmonary capillary membrane. So they want to transfer oxygen into the pulmonary capillary membrane and CO2 back into the lungs. And there's a lot of surface area to do this, which comes in contact with the capillary itself. Someone who has an obstructive disease, what happens is the tissue becomes destroyed, and also all of the convolutions in the alveoli become distorted, and so it loses the surface area. So if it loses all the surface area, the amount of gas that's transferred into the capillary becomes decreased. So decreased transfer of gas, mainly oxygen. Well, this has an increased capacity here because of all of the surface area. So there's an increase in surface area in a normal lung, and a decrease in surface area in someone who has obstructive pattern, because they have lost all of that surface area in the alveoli. So they may have a decreased DLCO depending on the severity of the lung disease. So this is someone who has severe obstructive lung disease. They're going to have a DLCO. Someone that has a moderate or mild COPD, obstructive disease, may still have a normal pattern. So again, that's going to depend on the severity of that particular disease. So overall, who benefits from pulmonary function studies? Surgical patients, obviously, are going to be the ones that we're concerned about. Anybody that's going to have severe COPD, they have a productive cough, they have severe wheezing, they're the classic pink puffers and blue bloaters that you're going to learn about. So anybody that has severe COPD, even severe asthma, even though it's reversible, may benefit from pulmonary function studies. Patients that are going to have any kind of surgery that's going to impinge upon the thorax, the chest, pneumonectomies, lobectomy patients, again, these are the ones that are going to benefit from surgery. Patients that have severe scoliosis, any kind of, they're doing Harrington Res on children or any kind of severe scoliosis that they're going to correct. Obviously, you need pulmonary function studies. Long surgeries in a prone position or lateral position that are going to affect your ventilation, they may benefit from pulmonary function studies as well. Last one is pectus excavatum. These are pediatric patients that they have a concave chest. Obviously, these patients are going to have benefit from having pulmonary function studies. But really, anybody that has the take-home really is anybody who has severe pulmonary disease, and anybody who's going to have any kind of large upper abdominal surgery or thoracic surgery. Those are the patients that are going to really benefit from having pulmonary function studies done. So again, it's the type of surgery. We talked about upper abdominal surgery, thoracic surgery, age. Usually patients that are usually anywhere greater than 70 to 80 years of age. If they're going to have large surgery, they often benefit from having pulmonary function studies. Smoking history, we said at the beginning of the lecture, 10 to 20 pack year history. Anybody who has an occupational hazard, asbestos or bakers or things like that. Anybody who is known to have severe COPD or restrictive disease. Anybody who has recurrent pneumonias. You hear that they have rales, rhonchi, wheezing. If you're doing your pre-op, people would benefit from pulmonary function studies. Anybody who has an abnormal chest x-ray, to further delve into why they have abnormal chest x-ray, pulmonary function studies are indicated. Another group of people that are on your slide, anybody who has morbidly obesity or any kind of chest wall deformities. We talked about pectus excavatum or spinal deformities such as severe scoliosis. Those are the patients that usually benefit from pulmonary function studies. I know at Sunset, when I went to the pulmonary function lab, they had also people that had a decrease in exercise tolerance. They had people come on treadmills that had severe changes in their lung volumes and EKGs. Anybody that couldn't climb a flight of stairs, those were indicated again for patients that had needed pulmonary function studies. We look at, if you order pulmonary function studies, do they need ABGs? Sometimes they're indicated, sometimes they're not. If a patient is hypoxemic or has severe carbon dioxide retention, again, they usually order PFTs. About 50% of the patients that come into the pulmonary function lab get concomitant arterial blood gases, and again, it depends on the severity of the disease itself. But again, we look at restrictive, a problem with volumes, not flow. Obstructive, we have problems with flow, not volumes, is our general guide.
Hi, I'm going to have a seat in the booth. This is pulmonary function testing. We'll be assessing patients' different parameters of their lung function today.
Okay, this is the mouthpiece. Your mouth's going to go all the way around that. You're going to have a nice tight seal with your lips. These are the nose clips. I'm going to plug your nose off so I can make sure everything's coming from your lungs and not your nostrils, okay?
First test we're going to perform is spirometry, and this is particularly good at assessing patients with COPD.
Okay, go ahead and put your mouth on. Nice tight seal. You're going to start out breathing normal for me until I tell you. When I tell you, you'll take a big deep breath in, blow it out hard and fast. And you're going to continue blowing that one breath out until we empty all the air out of your lungs. Once your lungs are empty, then I'm going to tell you to take another big breath in. Okay, big breath in for me. And blow. Push, 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 push. Big breath in real quick. Good job.
Next part of the test is plethysmography, and this assesses the patient's lung capacity, particularly good for assessing scar processes.
Okay, for this set of tests, I have to close the door for. Okay, your mouth's going to go all the way around that again. Clips on your nose. You're going to start out breathing normal until I tell you. When I tell you, take a deep breath in, blow it out, go back to normal breathing. Then I'm going to have you start doing quick little pants. While you're panting, you're going to meet a restriction. That's part of the test. I want you to keep panting through it, okay? I will talk to you over the intercom. Go ahead and put your mouth on. Nice, tight seal. For this test, I need your hands on your cheeks. Okay, nice, normal breathing. Okay, give me a breath in. Blow it out. Blow, 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 blow. Back to normal breathing. Okay, start panting for me. In and out, in and out, in and out. There you go. Keep going. Here comes the resistance. There it is. Keep panting through it. Doing good. Almost done. Okay, you can stop and come off.
Next step will be a diffusion capacity. This assesses the patient's lungs capacity, ability to take oxygen from the air and place it into their bloodstream. This set of tests, you're going to start out breathing normal. Deep breath in, blow it out. Another deep breath in, and hold it. You're going to hold your breath about 10 seconds, then have you blow it all out. Okay? Okay, mouth around for me. Nice tight seal. On your nose. Go ahead and breathe normal for me. Okay, big breath in. Now blow it out.
Blow, 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 blow. Big breath in. Hold breath. Keep holding. Keep holding. You're halfway there already. Keep holding. Keep holding. Blow it all out. Blow, 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 blow. Okay.
That completes our pulmonary function test.
This concludes the presentation on pulmonary function testing, pulmonary function studies. And what we will do is in class, we will have a brief overview of what we covered, and then we will actually go through some actual pulmonary function studies that were done on patients at Kaiser Sunset. I have some printouts, and we will go through those, and so you can see how the pulmonary function studies are presented and how they determine the diagnosis for these patients.